I welcome all our guests here today. It's lovely to see you all, and we really appreciate you coming and showing interest in this really important area. The national road toll reached a 15-year high this year over the past 12 months, with over 1,330 people dying on the road, and a 5% increase over the previous year, according to the NRMA. Further, over the past 6 months, 212 people died in an MVC or motor vehicle crash in New South Wales, a 13% increase. This mortality rate is bad enough. But what about the morbidity associated with MVCs? There are thousands left injured each year. The Australian Institute of Health and Welfare reported quite a bit over 65,000 people or hospitalisations from transport injuries in 2023-24. And data shows that for every road fatality, hundreds of people are hospitalised with serious road-related injuries. Road traffic injuries are an international public health concern, there's no question, with up to 50 million people suffering non-fatal injuries annually right across the globe. Of course, today I won't always focus on the negative, but it's important to point it out. Outcomes can be devastating and can result in substantial economic, social, physical and psychological burden. The WHO predicts that disability after an MVC will be a leading cause of global disease burden by 2030. This is why I believe this forum theme is hugely important, given the increasing impact of MVC injuries on mental health and well-being and the huge impact on compensation schemes. After all, if organising this forum is traumatic enough, what about an accident where there's deafening noise and you could have died? Hopefully the organisers won't die today, so we're fairly safe, I think. The burden associated with traumatic injury after an MVC is huge. May I say the cumulative burden. So there we are. So let's look at this topic. I'd like to just quickly go to a story that was published in a local paper that I wrote some years ago. And in fact, I actually wrote it thinking of Christine O'Donnell, who's just arrived. Welcome, Christine. She, having known Christine, I wrote that story really with her in mind. And that title, I believe strongly, and I hope you do too. There's no real compensation for pain and suffering. And generally, the compensation you get, which is great in this country, there's no question, it will never make up for what you've lost or experienced. So compensation and care provided by CTP and lifetime care, for instance, for severe injury after road injury is a huge benefit, no question. However, even if a person gains financial compensation and or support, it's not sufficient to address the well-being issue. Houston, we have a problem. Does anyone remember the year that this happened? The Apollo 13 mission? It was a dramatic understatement by astronaut Jim Lovell to describe the serious onboard explosion. Goodness me, that would be traumatic, in a little tin thing in space that threatened the crew's lives and aborted their moon landing in 1970. Well, we certainly have a problem with traumatic injury. There's no question about that. Time for some fantasy. How about we surgically adapt the body so we are less vulnerable to traumatic injury? Is that a way forward, do you think? What sort of body do we need to reduce risk of injury after a traumatic crash? That's a good question. And in fact, it was asked by someone called Patricia Piscini, commissioned by the Transport Accident Commission in Victoria, in conjunction with surgeon Dr. Christian Kenfield and Monash University researcher David Logan. And there we are. No hair, no neck. Obviously, whiplash is resolved. A helmet-type leg, head, TBI, well, less of a risk. The same size brain, of course, we can't adapt that. Lots of liquid to absorb the force. So there we have a side shot. Such a handsome fellow. His rib cage is fortified with organic airbags implanted in between each rib. The question I have, however, is what about the psychological strengths he would need? How do we adapt that? How do we surgically deal with that? Well, enough fantasy, I guess. I don't know if people remember that, but that I think is a lovely question to ask. I think the way forward would probably not go that way, given the adaptation that we need to make to our new bodies. The question then becomes, what is resilience? I would like to define resilience as within the person's environmental and social context. Resilience describes the dynamic process of maintaining stable and positive psychological, social and physical functioning when adjusting to the effects of disability and subsequent impairment. You know, academics always have these huge definitions, I know, but we need to cover every aspect. Resilience, however, is strongly related to two things, and one of them is called self-efficacy and the other is depressive mood. So we've done studies in resilience after injury, and it's not all bad news. So we, for instance, looked at some time ago factors predicting resilience in people with spinal cord injury. And the issue is that many remain quite resilient. And that's always, to me, a fascinating thing. Not being someone with a lived experience of spinal cord injury, I've always been amazed at how someone could suffer such an extreme injury and be resilient. In fact, in this research that I'm reporting, we found that most had a robust self-efficacy. And self-efficacy, if you want to define it, is the belief in your own ability to achieve a specific goal or perform a particular task successfully. So we all have some level of self-efficacy, and low depressive mood is self-defining. So we actually looked at self-efficacy over time and used self-efficacy and depressive moods as proxies for a measure of resilience. Because resilience really is a process. It's not something you can easily measure by self-report. It's a life process. And I guess you can only really experience resilience if you've suffered adversity. So we assessed how self-efficacy and depressive mood track over time from the acute stage to 12 months post-injury in 90 adults with spinal cord injury. And for our actuary over there, I'll give you some data. So we used a trajectory analysis from admission to 12 months post-injury, and using our self-report measures of self-efficacy, we assumed that this level here is really self-efficacy at a level that's satisfactory, whereas below that, it's not. So from the data here, around 60 to 70% had acceptable self-efficacy in spinal cord injury, with up to 30% having poor or decreasing self-efficacy over time. Now that's really interesting and suggests that it is not all bad news. If you looked at depressive mood and the same study, around 60%, if that's the cutoff point for the measure we used, below that, of course, is stable positive mood and above is depressive. So around 60% had stable positive mood over time 12 months post-injury with a spinal cord injury, while 40% had elevated depressive mood over time. So there we are. There's the figures of at least 60%, around 60%, 59.9, or is it 59 point something, having stable depressive mood. Well, that's spinal cord injury, that's severe injury. What about, what about in people with mild to moderate injury? Here we use post-traumatic stress as a measure. And of course, post-traumatic stress is strongly and negatively related to resilience. In a large database of over 2,000 adults injured in a motor vehicle crash, over 70% were coping well. And here we find the trajectories. So I'll just look here because I can see better. Many will remain severely burdened, around 16%. So 16% show real problems. And some recover partially over time. Some do recover over time, and the majority, about 50%, adjust really well over time. So even with mild to moderate injury, one has to consider that the outcomes aren't always favourable. In fact, we found a cumulative burden comes with a high cost to the community. And let's just look at a paper we published in BMJ Open some years ago, where we found that mental health problems have a substantial impact on compensation schemes. We examined over 30,000 people with musculoskeletal injury after a road crash from the JWCRR database, and who were participating in compensation. And they were mostly people with whiplash, skin, lumbar, and chest injuries. And we separated these people from that database into those with and without psychological distress. So psychological distress significantly increases days to settlement in people with musculoskeletal injury in those with psychological distress. So there we are. It increased psychological distress with the musculoskeletal injury, increased days to settlement from just over half a year in those with no PTS to around 1 year after injury in those with post-traumatic stress. Quite a difference. And of course, there's an associated cost with that. Psychological distress increases settlement costs in people with the musculoskeletal injury. So the costs increase from around 10,000, the lower bar, to almost 55,000 in those with PTS. So there does come quite an impact on compensation schemes. And of course, we're seeing now in work cover similar issues happening. Let me just go to a paper that we actually released to people attending. I believe it was available to you. The Cumulative Health Burden and Adjustment Challenges Following Road Traffic Injuries, published in a very nice journal, BMC Medicine. The team that produced this paper are up there. So let's just now go to the findings of this paper, because I think it's a really important paper. The majority of the injuries assessed up to 12 months post-injury involved head or face, neck, chest and spinal injuries. Mean age were 45 years at the time, but these are mild to moderate, not severe injuries. Most studies that assess traffic injuries related burden use limited measures to assess outcome, such as quality of life or years lived with disability. However, we believe that relying solely on one or two such metrics fails to capture the full magnitude of the burden associated with the injury and fails to communicate the complex dynamics of adjusting to chronic disability. Mental health outcomes are also used to measure adjustment to road traffic injuries. However, as biased as I am, mental health outcomes alone also fail to account for the emotional, health, societal and social burden after the injury. Therefore, what we did was we assessed a very wide range of outcomes after an MVC-related traumatic injury. I was once in a good mood, but I couldn't find any practical use for it. I rather like that because, well, we don't want to stay there, do we? We want to find something that lifts our spirits. So some of this research will dampen our spirits, no question, especially when this sort of thing happens. This is your lucky day, says the solicitor, you know, hardly. Can I just go quickly to, I don't know, most of you will have had an ECG sometime in your life. It's a painless, non-invasive test that records the electrical activity of the heart from which heart rate variability can be determined. Now, heart rate variability, which is what we do quite a bit in our research at the moment, funded by, not just by our funders here, but by the Ministry of Health, New South Wales Ministry of Health. We believe that heart rate variability is a very good and sensitive measure of resilience, mental health, and certainly of autonomic nervous system function. And using the R to R interval that I've shown you here. Now, this measure is very interesting. High scores, that is greater variability, is a healthy sign, while low scores, low variability, suggests reduced ANS or autonomic nervous system flexibility and dysfunctional cardiovascular activity. So your specialist in cardiovascular medicine will use this as a measure of your risk factors for heart disease. Low HRV is associated with increased risk of mortality from heart disease and an increased risk of a mental health disorder. So you might ask, what in the heck did Craig do this for? Well, part of that research in the cumulative burden paper, we looked at a number of factors. So there are different ways of measuring HRV. I'm not going to worry about defining these at the moment, but SDNN and RMSD, they just look at different ways of explaining the variability. In the cumulative burden paper I've mentioned, participants included 120 adults suffering injury after MVC and 112 controls who had not had traumatic injury in the past 5 years. The MVC had lower HRV, which is a real concern, higher arousal, heart rate, and inferior cognitive function. And if you look at the T values, whoops, just go back, there we see the statistical significance of those findings. The cognitive function thing surprised us because we are doing a lot of research in cognitive function after spinal cord injury, after a severe injury, but we were surprised that after a mild to moderate injury, that cognitive function sometime post-injury is also an issue. So this sort of research is quite concerning, but then we went on and we looked at, for instance, we looked at different things like pain severity. You can see the two groups. The circled one is the injured group. We looked at fatigue, distress, and they were poorer on cognitive function. So these 4 factors, I've just selected those out, were over a 12-month period. You can see that some are improving over time to 12 months, but still not getting to the point where non-injured people lie. However, distress and cognitive function were not improving. And remember, this is mild to moderate. Further, the injured group had reported greater financial strain. They were more likely to blame others and had higher feelings of perceived injustice. The MVC group had also higher perceived social support, which was interesting. This is one of the few that the injured group were performing superior to the non-injured group. But it's easily understood. Injury creates a situation where people seek out help, and that's good. The injured group had greater physical limitations. and higher SF12 was used, or SF12 measures were used here. So higher SF12 scores indicate superior or healthier outcomes. And we did measure resilience here, but still from a self-report, and higher scores indicate lower resilience, just to trick people, though both were improving over time compared to the control group. The injured group also had a higher occurrence of PTSD over time, and depression and anxiety disorder, so comorbid, and a high frequency of sleep problems. You can see that it's not great. I could go on. We could go on with other measures that the paper explored. There's something called symptom deficit disorder. Have you ever heard of this diagnosis? It's not real. Sadly, the road crash group cannot be accused of having symptom deficit disorder. As I said, I could go on, but what I'd like to do now is to look at what I consider and our team consider as breakthroughs in research that have real, I think, exciting implications for how we treat people during rehabilitation following injury. So let's look at some breakthroughs, and I won't deal with these in great depth. Again, I'm producing the journal and the authors. So the first breakthrough is something like this. Our findings suggest that autonomic nervous system function assessed soon after the MVC, and particularly lower parasympathetic activity, is a significant biomarker of long-term psychological distress. Such a biomarker represents a novel physiological signature for biological intrinsic vulnerability after injury. These findings provide direction for improved early identification and management of injured individuals, including innovative preventive interventions that target the dysfunction. After all, now HRV can be readily assessed in emergency departments with wearable technology. Many of you here will probably have such technology. Breakthrough 2. So what I'm suggesting is that we act on these breakthroughs. Breakthrough 2. We also developed, again, the team and the research paper and the journal. We developed a pre-injury vulnerability formula that indicates long-term risk of psychological stress using 6 socio-demographic factors that are readily assessed in emergency departments: age, sex, education, socioeconomic status, prior mental health and prior physical health issues. The high vulnerability group we divided into low versus high vulnerability had double the rates of PTSD and depression compared to those assessed as low and to the controls. Quite a significant finding. These measures can be easily measured in ED. Breakthrough 3. We found slow-paced breathing was highly beneficial for those with traumatic injury, especially for people with high psychological distress. Let me briefly explain. You may have seen this picture, but all of you being human beings have an autonomic nervous system, and therefore you have 2 arms to this. Not these arms, but parasympathetic and sympathetic arms. And the sympathetic arm is considered the accelerator of the body. A dominance of this arm can cause problems like hypersensitivity to stressors, high risk of heart disease and mental health problems. The parasympathetic arm over here of the ANS mostly acts as a brake on the accelerator. A dominance of the brake can also cause problems such as frequent illness, slow to heal after injury, dislike of exercise, and lack of motivation. What is needed for health is a balance of these 2 ANS arms, as a traumatic injury can be associated with increased imbalance, like a sympathetic dominance. An effective strategy is to use the brake. And what stimulates the brake? Well, it's breathing. Breathing, stimulated through vagus activity, stimulates the brake. I'd like to show you something that we are doing at the moment in spinal cord injury research in a clinical trial we're doing, where we're actually teaching people with spinal cord injury to improve their paced breathing or their breathing, the resonant breathing, and thus adjusting the balance between autonomic, the two arms of the autonomic nervous system. So this is the result of a person who's just started to learn. It's what we consider is really optimal. The blue is the breath rate up there, and the red is the heart rate during a paced breathing feedback session of their heart rate variability. And this, they've reduced their breath rate down to 7 per minute over a 14-minute period. However, ectopic, abnormal heartbeats are occurring, and the resonance between heart rate and breathing is very poor. Now, after some weeks, I think it was 5 weeks, about 5 weeks of training, guess what? Look what happened. I presented this to a medical conference in Edinburgh a couple of years ago, and there was a gasp in the room because people understood the implication of this. This has real potential, this breakthrough. And let me say that relaxation is not something you can do quickly. You've got to learn to do it. So it doesn't work like that. So breakthrough 4 is all about cognitive. Now, we've already mentioned that cognitive function after mild to moderate is an issue, but certainly it's an issue after severe injury, in spinal cord injury, and I would imagine in severe TBI. We believe this is a breakthrough. This is certainly an important area of research and outcome, and it should be monitored more so than it is. So in spinal cord injury, we've actually shown through a meta-analysis that executive and attention are two factors that really do need attention. And also, I've already said that we've actually found that in mild to moderate, the same sort of thing is happening. So cognitive needs to be monitored more seriously after traumatic injury. And breakthrough 5, catastrophizing. We probably were doing, the people who were organising, we were catastrophizing quite a bit, I can tell you, over time. But it's a top-down factor, and is significantly associated with injury. Mark Twain said, "I'm an old man and have known many great troubles, but most of them never happened." So that essentially defines catastrophizing, which involves elements of feeling very helpless and pessimistic about one's pain or life, ruminating and magnifying the effects of whatever is troubling you. The implication is that psychological intervention in rehabilitation after injury should be designed to help patients manage their cognitive bias, like catastrophizing, with the aim of improving their mental health. And when you look at the difference in catastrophizing between those two groups, you can see that the traumatic injury group catastrophized much more. And we found similar results in spinal cord injury. Also, you can see here, this is a spinal cord injury paper, but during the acute stage where they've got lots of support, those who are depressive and those who are not have similar levels, not significantly different levels of catastrophizing. But after discharge, the people who are depressive catastrophize far more. And it's probably obvious why. Less support, more challenges and so on. We've also recently found that heart rate arousal is significantly elevated in adults who catastrophize, regardless of injury, when completing a mildly stressful task. So you don't need to have an injury to catastrophize. I'm sure all of you have catastrophized in your life. You don't have to confess, but it's not good. And we also showed that heart rate variability is affected by catastrophizing, which is a top-down, as I said, a top-down factor. There are a lot of implications for this. This is very concerning. And latest research from evidence from our research and others is indicating that chronic catastrophizing negatively influences brain function, exposing people to increased problems like pain, depression, anxiety, and cardiovascular disease. So catastrophizing does alter the way the brain functions, so it's a critical thing that it's addressed in psychological or psychosocial therapies, especially in disorders where catastrophizing is prominent, like after a traumatic injury. Did Einstein, that's Albert, by the way, did Einstein define insanity as doing the same things over and over again and expecting different results? There's actually some controversy over whether he actually said this. If so, he was talking about, or in the context of physics, but we do not want this applying to the rehabilitation of people suffering the effects of traumatic injury. We need to implement breakthroughs like this into practice. Thank you very much for listening to me, and I'll leave you with some shots of Fagan's Bay, which is where I live, or near anyway. I don't live in the bay, but I live near it. Thank you very much.